Now we're going to see the primary survey of the ATLS as a whole. In the next videos we're going to see in detail each part of the primary survey, but for now this is like a whole or some generalizations of the primary survey. So primary survey, we already saw in the last video that first we focus on the airway, which is A, and we always add airway and control or immobilization of the C-spine or cervical spine. Then B, which is breathing, and we also add ventilation. Then C, which is circulation and control of the hemorrhage. Then deficit, neurological deficit. And then E of environment control and exposure. So a summary of all this is what we are going to see. In the next videos we are going to see each part in more detail. So starting with A. A is airway and control of the or immobilization of the cervical spine. So first of all, what we want to evaluate is if the airway of the patient, of the injured patient, is not obstructed. So we are looking for obstruction, which could it be because of a foreign body. If we find a foreign body, we need to remove it. We also look for secretions. If we find secretions, or if the patient vomits, or if we find blood in the oral cavity, we need to aspirate it. Also, we are looking for injuries that can compromise the airway. That could be lesions on the lesion of the trachea, lesion of the larynx. Also, if we have facial trauma, that could compromise the airway. So in each of these cases, facial trauma, a lesion to the trachea or laryngeal lesion, we need to intubate the patient. Also, if we have a Glasgow Coma scale of less than 8, the patient should be intubated, because this is talking about a serious damage to the brain, and the patient needs to be intubated. Or maybe the Glasgow Coma scale is not 8 or below 8, maybe it's greater than 8, but if in the presence of the clinician that is examining the patient, the Glasgow Coma scale drops or deteriorates for more than 2 points, then the patient should be intubated. For example, if the Glasgow was 13 and some minutes later the clinician reevaluates the patient and now it has in Glasgow Coma scale of 10, that was a drop of 3 points, so more than a drop of 2 points. So the patient needs to be intubated, even though as a whole the Glasgow Coma scale was more than 8. So it's talking about a fast deterioration. Also every injured patient should receive supplemental O2. This would be by a face mask, like a reservoir mask, which we can easily put to the patient using the jaw thrust maneuver, or the chin lift maneuver, to correctly position the patient in order to put the mask reservoir. Or if the patient is unconscious, we can use an orotracheal cannula. So these are some generalities of the airway, and we always need to be careful to protect or immobilize the cervical spine. So even though we manipulate the patient for us to ventilate the patient with a mask reservoir, for example, we always need to control or immobilize the cervical spine. So one clinician or one person takes care of the airway. It could be like ventilating the patient, while the other clinician immobilizes the cervical spine. So for example, here is the patient. One clinician is going to ventilate the patient. So he is accommodating the mask. He is ventilating the patient, and the other clinician needs to immobilize the cervical spine. So this maneuver is called lineal traction. This clinician gives lineal traction, which is immobilizing the C-spine, while this clinician is manipulating the airway. So always consider immobilization of the cervical spine until it is discovered that the patient has no cervical spine lesion. But at this moment, we have only focused on the airway. We have just evaluated the airway, so we have not confirmed or discounted that the patient has cervical spine injury. So we always treat the patient as if it has cervical spine injury until proven otherwise. So every time we manipulate the airway, we should immobilize the cervical spine. And for example, if the patient was wearing a motorcycle and he has the protected head, we should take it away. So we need two clinicians to take it away. One clinician is taking it away, while the other is maintaining immobilize the cervical spine. So here we need like to open it in order to pull it, and this one is immobilizing the cervical spine and maintaining or sustaining the head of the patient. So this is generalities of the airway. Now we go to breathing and ventilation, because one thing is that the airway be permeable or not obstructed, but the other thing is that the patient can breathe or can ventilate or can move the diaphragm. So for the patient to be able to do the exchange of O2 and CO2, which is what we measure, is not only the permeability of the airway, but also the rib cage, the movement that encourage the exchanges of O2 and CO2. So for breathing and ventilation, we care about the lungs. For also about the chest wall, lung, chest wall, and the diaphragm. So an injury in the lung, chest wall, or diaphragm can compromise the ventilation. So if a patient is desaturating, even though the airway is permeable or not obstructed, maybe it could be because of an injury to the lung, chest wall, or diaphragm. So here, breathing and ventilation, we should evaluate this. And as we said, every injured patient should receive supplemental O2. Here, we should focus in identifying the lesions that could compromise this breathing and ventilation, that could potentially kill the patient. So these lesions are pneumothorax, which we are going to see in more detail in next videos, hemothorax, and the lesions to the trachea and bronchi. These lesions could potentially kill the patient at the event, or almost at the event. So our priority is to diagnose these lesions for us to treat them. There could also be some other lesions, like for example pulmonary contusion, but that will not kill the patient at that very moment or that precise moment. So that for example, the lung contusion is diagnosed in the second survey, not in the primary survey, which is just treating or just focusing in identifying the lesions that can kill the patient at that precise moment, or almost at that precise moment. So these are the most important lesions to detect. There are some others that can compromise breathing and ventilation, but those are identified on this secondary survey. Or for example, flail thorax, that could also compromise ventilation, but that is not going to kill the patient. So that is not diagnosed or evaluated at this precise moment. Also, we need to always consider that the patient could have an open pneumothorax or a pneumothorax, that after we put an endotracheal tube, we can convert this open pneumothorax into a tension pneumothorax. So if we have a tension pneumothorax, the treatment is just descompression with a needle or with a pleural sonda. But if the patient has open pneumothorax and we didn't notice the patient has open pneumothorax, and we introduce an endotracheal tube and we are ventilating the patient, we can convert this open pneumothorax into a tension pneumothorax. So before placing an endotracheal tube, we should always discard the patient has not an open pneumothorax, which could it be converted into a tension pneumothorax after introducing the endotracheal tube. Also, if we cannot intubate a patient, I will put it here. If for some reason we cannot intubate the patient or is contraindicated, we should go to a surgical airway, which is cricotomy, but we'll see that later. So these are the generalities of breathing and ventilation. Now, circulation and control of hemorrhage. Here we focus on the blood volume, also of the cardiac output and the hemorrhage. So the most common cause of shock in a traumatized or injured patient is hypovolemic shock, specifically because of the hemorrhage. But before evaluating the circulation, we are evaluating ventilation, breathing and ventilation. And here, a potential cause of shock is the tension pneumothorax. So if we have a patient and just by evaluating the vital sign, we suspect the patient is in shock, first we need to discard the patient has tension pneumothorax. Because after airway, what we evaluate is breathing and ventilation. So at this point, we should discard the patient has tension pneumothorax, and if this is excluded, then we suspect that the cause of the shock is hemorrhage. But this is after excluding the reason of the shock is not tension pneumothorax. And now, talking about the hemorrhage, we can have external hemorrhage and internal hemorrhage. Being external hemorrhage is the one that we can see. When we have external hemorrhage, we control the external hemorrhage by applying pressure to the injury to the lesion that is bleeding. And if after applying pressure for 5 to 10 minutes more or less, that does not control the bleeding, then we can consider to apply a tourniquet. But we should have in the consideration that the tourniquet could cause ischemia, can cause ischemia of the extremity, for example. So we will only apply tourniquet if the life of the patient is in risk, because we should only consider the extremity could get ischemia, or worse, can get necrosis. So this is for external hemorrhage. First, applying pressure, and if that does not work, then application of a tourniquet. Now, talking about internal hemorrhage, we can have accumulation of blood in the thorax, accumulation of blood in the pelvic cavity or the abdomen, and in the pelvic cavity we also have the retroperitoneum space. So we have 3 spaces where blood can be accumulated, which is the thorax, the abdomen, and the retroperitoneum. But in the pelvic wall, or at the level of the pelvis, we have some of retroperitoneal structures. Also, if we have a fracture of the pelvis, the patient can lose from 2 liters to 5 liters of blood, and all the blood amount of the patient is like 5 liters. So just because of a pelvic fracture, the patient can lose all his or her blood volume. And also, long bones can bleed a lot, specifically a femur can bleed from 1.5 liters to 2 liters. So if we have a patient which is in shock and we already excluded that is because of tension pneumothorax, we suspect is because of hemorrhage. And now we can have external hemorrhage, which we will apply pressure to the lesions, or internal hemorrhage, which could be because blood accumulating in the thorax, abdomen, retroperitoneum space. It could be because of a fracture of the pelvis or fracture of long bones, for example, the femur. And to diagnose this, we should do the FAST, which is Focus Assessment Sonograph ultrasound, which is an ultrasound where we evaluate the heart, the hepatorenal space, the space between the kidney and the spleen, and the fundus of the bladder. There is an expanded FAST which also evaluates the lungs. But evaluating these four spaces, the heart, which specifically is the pericardium, and these other three, we can evaluate if we have accumulation of blood. And if the FAST is positive, then we need to take the patient to surgery. And to evaluate for bleeding because of a fracture of the pelvis or fracture of a long bone, we need radiographs. So for that, one of the first radiographs we get is a radiograph of the pelvis, which we will see in more detail in the next videos. But for that, it's important almost at the moment the patient arrives to take a X-ray of the pelvis. Then, because we will probably need to transfuse blood to the patient, we need to canalize the patient. So when we canalize the patient, we will have two peripheral lines, and the width of the diameter of the catheter should be very wide and short. The length of the catheter should be short. So we need two peripheral vias, and the catheter should be wide and short. And at the moment of canalizing the patient, we should take blood to send it to the laboratory, because we will need hematologic studies. We will need some chemistry studies and the coagulation times, TP and TTP. So as always, we need the only blood test that we always order, and specifically if the patient is a young woman, we will also add the fraction of the gonadotropic chorionic hormone, because we need to evaluate if the patient is pregnant or not. And we also need to match the blood. So before canalizing or at the moment of canalizing the patient, we need to take blood to send it to the laboratory and to the blood bank. And also, if we have a patient we think is in shock because of hemorrhage, we need to administer 1 liter of crystalloid solution. Specifically, it has to be crystalloid solution, not for example glucose solution or a solution that contains glucose. It needs to be crystalloid solution, and it has to be 1 liter. Before, we used to infuse like 2 liters or 1.5 liter, but this increases the mortality in patients because we are overloading the patient, and this is not the issue. The reason for which the patient is having the shock is because he's losing blood. So it doesn't matter how much liquid we introduce to the patient, this is not going to cure the patient until we does not resolve the problem of the hemorrhage. So we does not need to introduce a lot of liquids, we just introduce 1 liter of crystalline solution, but we need to control the hemorrhage. And the solutions that we are introducing needs to be warmed. Specifically, the solutions need to be maintaining at a temperature between 37 and 40 degrees. And at the moment of infusing to the patient or introducing to the patient should be around 39 Celsius degree, around 39. And this, we could use a warmer or a microwave to warm the solutions, but we cannot warm the red blood packs in a microwave. We can warm the solution, but not the blood we are going to transfuse the patient. So also the patients that the traumatized patient or the injured patient has some tendency to have coagulation disorders. This means the patient has increased risk of bleeding. So what we can do is, before the patient arrives to the care facility, it could have administration of tranexamic acid, which is an antifibrinolytic. So this promotes clotting, and it should be administered in bolus. If the patient got the tranexamic acid before arriving to the care facility, so after 8 hours we need to administer another dose of tranexamic acid. And if it is going to be administered the tranexamic acid before arriving to the care facility, it should be administered between 3 hours after the lesion or after the event. If it has happened more than 3 hours after the event, then there is no reason to administer tranexamic acid. So these are generalities of the circulation and control of the hemorrhage. Now the deficit, neurological deficit. So here we evaluate the Glasgow Coma Scale. We evaluate for pupils. We evaluate for signs of lateralization. It could be like evaluating the motor aspect of the patient. And we also evaluate for spine injury. If we suspect some injury to the spine or the brain, the patient should be transferred to a care facility that has neurological and neurosurgery doctors. And we should always consider that the reason for which the patient has the deterioration of the Glasgow Coma Scale is because of the brain injury. But also something that can perpetuate the injury to the brain is hypoxia and hypovolemia. So not always, if the patient has a Glasgow Coma Scale less than 15, not always would be just because of the trauma to the brain. It could also be just because of having hypoxia and hypovolemia. So the most important thing in maintaining or taking care of the brain in a traumatized patient is not to have hypoxia nor hypovolemia. And so we need to reevaluate the neurological examination of the patient frequently, because very very fast the patient can deteriorate because of the trauma to the brain. And also, if the reason for which the patient has low or Glasgow Coma Scale less than 15 is just because of the hypoxia and the hypovolemia, and maybe the patient does not have brain injury. So after controlling the airway and the breathing and ventilation, we should evaluate again the Glasgow Coma Scale. Also, the reason for which the patient has deterioration of consciousness could be because of hypoglycemia or ingestion of drugs, for example. And now the environment and exposure. So we need to take away all the clothes of the patient to evaluate all the patient to see where the patient has the lesions. But we should take care of not cold the patient. The patient should be maintained in a warm environment to maintain the normal temperature of human, which is 36 to 36.5 to 37.5. So the traumatized or injured patient has a tendency to a less temperature or a low temperature than normal. So after we expose the patient to see where the patient has lesion, very soon after that we need to cover the patient with warm things, and for that the solutions that we infuse to the patient should be with around 39 degrees to warm the patient. We should take care not to freeze the patient or infuse solutions that maybe would be at ambient temperature, for example 37. But if we infuse a lot of these solutions and we also need to transfuse the patient, red blood packs, these are cold, so we can cold the patient at the moment of transfusing the patient. So for that, the crystalloid solutions need to be at 39 degrees to warm the patient. So in summary, the primary survey is treating the things that could potentially kill the patient at that precise moment, and we first focus on airway and control of the CS pipe, then breathing and ventilation, then the circulation and control of the hemorrhage, then the neurological deficit, and the environment control and exposure of the patient, and control of the temperature of the patient. If the patient does not respond to 1 liter of crystalloid solution, then we should transfuse blood, but we does not add more crystalloid solutions because that could potentially aggravate the coagulopathy disorders.